Dear Facebook Pure Urology viewers, good evening one and all. As you know, we are doing this surgical technique based presentations every alternate day or the other day. Today we are discussing about the retrograde intrarenal surgery in different clinical scenarios. You all know that the management of the renal stone disease is changing dramatically. In the last decade, the retrograde intrarenal surgery has come way forward and replacing some of the indications of Pcnl as well as ESWL. But however, RIRS sometimes is a difficult surgery like in ectopic kidneys or abnormal ureters or ileal ureters, like that various clinical scenarios like in diverticular stones. It may be difficult. Everybody may not be able to succeed. Either you have to go for antegrade approach or you need expertise. Today, our speaker is my close friend, Dr. Datson George from Kerala, and he is interested in RIRS. He developed interest 10 years back. Slowly, he became now experienced surgeon. From day one, he has shown interest in RIRS and started collecting the clinical scenarios where it was difficult. And apart from the laparoscopy skills, he developed this RIRS skill independently in his hospital at Kerala. So, hi Datson, thank you
Hello,
for
sir.
joining.
Thank you, sir. Thank you, sir.
Datson, I just wanted to ask you briefly,
Yes,
where
sir.
did you do your MBBS?
Sir, I did in SRMC at Chennai, BBS,
Chennai
MS
SRMC.
there, and
MS also
MCH.
SRMC.
Yes, sir, and MCH at Amrita. So,
Oh, MCH
Amrita
at
at Cochin.
Amrita.
Yes, sir. Yes, sir. MCH.
Dr. Bhatt was there at that time?
Yes, sir. When I joined, but sir was there for 3 months, sir. Then he left.
Who was your mentor during MCH?
Sir, MCH, sir, but sir was there for some time, sir. Then Apu Thomas, sir, Sanjeevan, sir, both of them were there. Sir.
Okay, okay.
Okay.
Your first RIRS surgery was done during MCH or afterwards in your private practice?
No, sir. Afterwards, in private practice, immediately after MCH, I joined with Dad, Dr. George P.
Yeah,
Abraham.
yeah,
So
yeah.
then, as this was coming up, this was around in 2012, sir. So it was slowly coming up here and there in 2 years.
Yes, yes,
So
yes.
then I thought I will slowly start using, and the first surgery was done at Lakeshore itself by
Yeah,
by
yeah.
by myself.
So,
It was
what
done
was
there.
your initial scope when you started using? What was your initial scope?
So initially it was the Wolf Cobra initial
Okay,
the bigger one. So that was
okay.
that was it used to go only in the 12-14 access sheath, and
Yeah,
that
yeah.
was how initially it was bought there and slowly started, and single small 9 mm 1 centimeter stone in the pelvis, and all pre-stended cases like that we started. So then after that we went
Okay.
into the smaller scopes and came. The first scope
Uh,
actually
uh,
stayed for quite a long
off
cases.
late, off late, what scope you are using most often?
Sir, now use the Olympus P7,
P7
and
more.
yes, and FlexX 2S. And
Flex
recently
X2S.
we have got that the OTU, sir, the OTU scope which goes in 10,
I
12,
heard it is
10.
also good. OTU
It is
scope
good,
is
sir.
also good.
It is really good, sir. Actually, I started using all good cases. Big stones also have been done. Actually, now the first scope I used, it has come for around 14 cases, sir. Not much problem with the
Okay. Is
deflection.
there any time bound in OTU scope?
No, sir,
Time.
no, sir, no time bound, but they say by around 18 to 20 cases, according to how we use, the flexion becomes less, the lower calyx flexion. Sir. The upward flexion might still
Okay.
be present, lower might go off, but still now the flexion has become a little tight, sir, but it is we can use it. The only thing is that, sir,
Okay.
it goes only in the 10, 12 access sheet.
10 12 access sheet.
Yes, sir, the
Better than
P7.
12 14. 10 12
Yes,
is
sir,
better a little.
definitely,
So
sir. And
all these scopes like Biorad, Indovasive, Pusen,
yes, sir.
these all going at 10 12 10 12
Yes, sir.
size.
Yes, sir. Yes, sir.
Which laser you are using routinely?
So we have the luminous 100 watt. That is the only laser
Okay.
we have, sir. We started in that only, the
You are
RARS. That is
comfortable
still.
with laser lithotripsy with luminous 100?
Yes, it's okay, but the thing is, sir, actually, we want to go for the thulium laser because
Yeah,
the
yeah.
fragmentation rates and the time for fragmentation is very less. I'll be showing only one case I have done in that. So I'll be showing in this for a demo.
Very good.
So I'll
Yeah,
show
yeah.
that, sir. I'll show in that. Yes,
Good.
yes,
And with that introduction, I will share the official presentation of yours. After that, we will move to the different clinical scenarios which are going to present today.
sure,
So,
sure,
dear
sir.
colleagues, Pure Urology is the Facebook forum where we have 7,400 nearly odd urologists, and we are primarily focusing on the surgical techniques. Almost we have done around 145 surgical techniques so far with 145 different surgeons. Today, our talk is RIRS in interesting scenario. Dr. Datson George P, who is from Kerala, and he is consultant urologist and renal transplant surgeon at VPS Lakeshore Hospital. He introduced RIRS in Kerala first time and has completed more than 1650 surgeries. He has performed more than 2,500 laparoscopy urology procedures and around 6,000 endourological procedures. He is very active in cadaver and liver transplant program and has performed more than 290 renal transplant surgeries and 500 lap donor surgeries. He also with Dr. George P. Abraham had started 3D vision laparoscopy in Kerala and is one of the few urologists doing a regular 3D laparoscopic surgeries. He is running a regular laparoscopic training and fellowship program and has been the invited faculty at several workshops and conferences. He has co-conducted 5 international live workshop lap endofusion, which showed all varieties of advanced laparoscopy cases and endourology cases with over 500 delegates participating from all over India. In fact, I was also one of the faculty fortunately in the last one or two, and it is a fantastic program by Dr. George P. Sir as well as Datson George and this team. He has recently been awarded the Best Consultant Urologist in Cochin for his contribution in the field of the urology. With this introduction, and I will once again thank Datson George for accepting this invitation.
Thank you, sir.
Datson, over to
Yes,
you
sir.
for the talk. Thank you.
Okay, sir. Okay, sir. Thank you, sir.
Yeah, it is visible.
Thank you, sir. Thank you, sir.
Yes.
Uh, Good evening, everyone, respected teachers and dear friends. Thank you very much, Chandramohan sir, for giving me this opportunity in Pure Urology to present in this great forum. Thank you very much, sir. Today, I will be showing a very short video clips of multiple scenarios in RIRS and how it was managed. So we'll go on to that. Our usually a lower calyx is an area of interest for all the urologists everywhere. And as we all know, life of fluxiscope definitely enhances with the use of the basket for the lower calyx for relocation to another position. Definitely a 200 fiber is the one to be used in the lower calyx if you're lacing lower down, and never pass a laser fiber in the deflected state. I'll be showing few short video clips of certain stone management in the lower calyx. This is a stone actually in a malrotated kidney. And here, what we have done, the stone is actually mobile. Always we try to basket the stone to take it out with the engage or encircle basket. But you can always, sorry, yeah, you can always, there is an option to use the basket to go around the sides of the stone, behind the stone, posterior to the stone. You can open the basket multiple times so that it might even push the stone upwards. So if you are not able to basket the stone, sometimes even moving just the basket all around it with the flower of the basket at multiple places can shift the stone to a better location so for the lacing purpose. Now, this is another stone. As you can see, this stone is in the lower calyx. About 80% of stone is cleared, but at one point we can see the stone is stuck there, and you're not able to bend the flexi more than this point. Here again, I'm just pausing. At this point, what it is, the our assistant is very important. He uses the water. He uses our water to definitely move the stones and complete. As you can see, this is what we are doing. The stone is there at the lower calyx, we have fragmented. Now that part of the stone is stuck there. The assistant flushes the lower calyx, the stone fragment moves. At that point, the fiber is kept there. The scope is not moved. With move the flushing itself, the stone is moved all around so that the stone comes in front of the laser, and we lace it and completely moves it. This is another scenario where it is in the lower anterior calyx. So when you go very deep down and you see the stone there, you can see it is slightly embedded. That so whatever you do, whether you do put a basket, you will not be able to get this stone. So at the deflection, at the difficult deflection angle, you put with maximum pressure on the flexi, you can extend the laser fiber as much as possible to clear the stones and come out of certain lower calyx. This is another small video where always we definitely basket the stones, but even with the flexi itself, we can go towards the back of the stone, the side of the stone, but all the time under CM guidance to move the stone to a favorable location to break the stone. Here you can see with the stone, with the flexi itself, slowly we are pushing the stones. All these stones, it is possible in the lower calyx when the stones are mobile. And other than basketing, these are the slight. So combination of all these methods can sometimes help in mobilizing the stones from the lower calyx. Here, there is another stone which is visualized on the CM and everywhere, but on going inside, we are not able to just see the stone. This certain people like pilots or merchant navy and all these people, whatever the size of the stone, everything has to come out. Otherwise, they will not be taken back for work. So when you see this, basketing is not possible. You can go inside, cut open the mucosal layer, fragment it completely with the laser, dust it well, because you have to get all these things out of the lower calyx and flush it out, and all the fragments need to be taken out completely. Otherwise, it will be remaining in the lower calyxes. Another lower calyx where here you can see the stone in the CM picture there. You have gone all around the kidney. Again, it's not seen. You can see one darkish area where the part of the calyx is closed. So we are almost sure the stone is behind that. Again, with the laser, we can open that area, go inside, and clear the stones. The only thing is we have to be very careful of the flexion in the CM. Initial and RGP would make sure that whether the stone is inside the system or outside, or whether it is reachable or we can go into it or not. So these are certain things where we can go into the lower calyx. This is a stone, as you can see. This is a stone very uh, in the right, in the CM pictures, first and second CM pictures, we have reached the lower normal lower calyx which is seen there. After the stone is in a very difficult acute angle anterior calyx. So after this point, we make use of the passive deflection of the scope to bend. As you can see in the third CM picture, you can see part of the stone there. We have reached into the stone. Only thing is, from that point, luckily the stone is mobile. We ask the assistant to flush it. The stone comes out into that is the calyx, the difficult calyx. That is the time when we took the third CM picture. It's completely bent. Now we can see the stone has come into the lower and favorable anterior calyx, where in the fourth CM picture also you can see the stone has moved up while my scope is still in the difficult calyx there. So from this, easily we can basket and take the stone out. In such cases, what happens is the stone is there and we go in. We should always do an RGP to find out whether the stone is inside the system or not. Because initially, when we see, we should also always look the normal calyces, the lower calyx, and come out. But there will be one hidden calyx here and there, which we need extra work to go inside and take out the stones like this. Then only the stones can be completely cleared. Here again, this is around a 2 centimeter lower calyx stone. The problem was, for this stone, we tried everything like putting the basket, moving the basket by the side, pushing with the flexi and all that. It is the lower part is little stuck there. So what it did was, even with the our laser fiber, we can create a island, like that is with the flexi. We are trying with the basket, we are trying to mobilize or get the stone, or with an island. We with the laser fiber on top of the stone here, I created a small island there where the basket can be held. And holding that, luckily the stone came out of the calyx. It is quite a large stone, I believe, when it has come out. So if I not got that small island by cutting that part of the stone and making it rugged, then we would not have gotten the stone out of this calyx. So this is another technique which can be tried, and rather than going to the basket and trying to hold the stone as a whole, because it might not be possible, and you will not be able to reach the stone because of the deflection and the acute angle. So try to make a ragged edges of the stone so that the basket hooks onto that and you can take it out like that. All these encircle basket were used for these cases. This is another patient. You can see in the CM picture, sorry, in the CT picture, it's definitely a large stone and very acute angle, and you can see the CM pictures also. So initially, what we have done is I tried putting the basket holding the upper part of the stone and pulled multiple times. It is coming in, but it is not going. So when we find that we are not able to get it, break half of the stone so that we create some more space in the kidney, so that around half of the stone is cleared. Then you can go in, put a basket, try to get all the methods which we have told can be tried. Hold one small area of the stone, and that the stone was lifted offward. So here the lower calyx stone was made into two halves. The first half was cleared with the laser. We created space. The lower half was basketed and it came out. You can see the CMP. Once the lower half major stone bulk was taken out into the kidney and fragmented, you can see in the CT picture there's another secondary two stones. That's the last CM picture what we are showing. You could go into the last secondary stones area easily with the flexi when the major stone bulk was out, and we could clear it. So the deflection, everything has to be done under CM guidance, and the basketing also. This is definitely area of the stone. It is again in the lower calyx. We sometimes reach, we find certain fragments like this. It sits at the side and we try to basket here and there, everything we tried, but it's mobile with the flushing technique. So again, the assistant tries a new technique. He keeps the basket open, flushes it multiple times, and catches it like a ball and takes out. So this can be done when major small fragments are there and it is not coming into your view when you are trying to take out the fragments. So that this happens to us multiple times. We will see a fragment, we will go there. Basket might the engage or encircle might not reach there. It might be standing at the side. We can always use the flushing by the assistant to move the stone to hold it and catch it. This is again a difficult case, definitely lower calyx, a very narrow infundibulum, as you can see in the CM pictures. Half of the infundibulum is blocked with the stone. So you can see the CM pictures. So after again we go with the flexi. That is the infundibulum opening, what we can see. With the flexi itself, I went inside, so the infundibulum is little dilated, but after a point, you can see the deflection of the flexi in the CM pictures. We are not able to go in. So after a point, we go inside, we move the flexible scope with the passive deflection and with the laser extending quite a bit inside. You can see the depth, once the infundibular stone is cleared, you can see the rest of the callus which is left behind. So only thing is, in that is the callus after the stone is completely cleared. The thing is, I tried to clear the stone dust as much as possible, because below this it will be difficult for the flexi to reach, because I am at the maximum deflection along with the passive deflection, otherwise it will not reach there. And we should maximum try to flush all these small fragments which is out of this, because it's a very dependable calyx, and if you leave it there next time also it is difficult. One more option, I placed a stent into that system, so that by any chance, if you need to do a second look, he can go in. Maybe the infundibulum or the part might get a little more dilated to have a look inside. I definitely did a second look in this case, but it was around 99% was clear. Few tiny dust was there, which was flushed out. So now, always we have a scenario when the basket is it gets stuck somewhere in the lower, middle, or upper calyx, and it is so we broken, and we go inside and break it and take it out. This was one area when actually it was a lower calyx around 2.5 to 3, 2.5 centimeter stone. Went inside, held the basket inside. The problem was the proximal part of the basket just broke off, and the distal whole 4 centimeter basket, which I have marked in that blue line, the whole thing was stuck inside the kidney. So the proximal part came out and the basket is inside. So I didn't know what to do. This was the stone I was breaking. I was pulling. This was the whole thing which was stuck inside the kidney. So there was nothing to pull or to cut. So what I did was I went inside. Somehow I cut few. There's a few basket areas I have also cut, but after that also the problem was there's nothing to hold on to it. So what I did was with great deflection, with great difficulty, went in and broke the scope so that at least the upper part is free. Then I searched all around and finally found out the part where it was broken, the whole basket. With the flower, the basket 4 centimeter with the flower, it was inside. So I put another basket, held into that small part of the normal basket and pulled one out. So this can happen, but it is very rare. Usually, basket gets stuck, and you can cut two flower strings, and it might come out. Or else you can break the stones and take it out. You can always go by the basket. You can dismantle, go by the side of the basket, again go and take it out. But this I had to show because the whole thing was stuck inside, so no other option was
Excellent,
there.
excellent. This is
Thank you,
rarely
sir.
happens.
Yes, sir.
Datsun, this is
Thank you,
very
sir.
rarely happens.
Yes,
And
sir.
taking the piece out is, I have stopped and did PCNL at this stage, but
Oh,
you
okay,
have
sir.
gone and then removed this small piece.
Yes, sir.
Sometimes these type of small wires may not be detected on the C-arm, so you have done excellent
Yes, sir.
job.
Thank you so much, sir.
Speak
Thank you.
slowly. You have good cases collection. There is
Okay,
no
sir.
hurry.
Okay,
Excellent
sir.
cases you are showing. Don't be in
Okay.
hurry.
Okay, sir. Okay, sir.
So a
Okay.
lot of people are joining slowly.
Okay, sir.
Now
Okay,
already
sir.
100 are watching, so go slowly and explain what you have done.
Okay, sir. Okay, sir.
Yeah,
Okay.
please. Great.
Thank you, sir. Thank you, sir. Now, that was the lower calyx few instant for areas of management which I had shown. Now we will go on to few more the scenarios that which I can show. One is a large calculate.
Before
Large,
we go regarding
yes,
inferior calicial, that's when
yes,
I disturb you a bit.
sure, sure,
One
sir.
question from Vivek Punuganti. He's
Yes,
recently doing a lot of RIRS
okay, sir.
in periphery, I think Karimnagar, I think. Have
Okay,
you
sir.
tried making hole in the store and then lift it up?
Yes,
Kandar
sir.
Pariks are also sometimes show.
Yes, sir.
They dig this laser fiber. If it is small stone, you
Yes,
can
yes,
just lift. Yeah, that is
yes.
also one method. You also do it.
Yeah, I also do it. I've done around six cases, and I've shown it in
Yeah.
one of the Lapender fusion also. One case.
Yes, yes.
So that was a
That
low.
can be done.
Yes, that can be done.
That only.
Only problem, sir, is when we do that, we have to be sure about the size of the stone and the laser fiber when you're lifting from the lower calyx. If you have any traction on that, just leave it. Otherwise, you're damaging the fiber
Yes,
as well as the
yes.
scope. That is the only
Yes,
problem.
very important point is blast sheet also can go if you
Yes, sir.
pierce too much and fire laser.
Yes, sir.
So he
Backfiring.
said correctly, backfiring is a very high possibility, especially in homium.
Correct,
So
sir.
in all the cases, it may not be possible. With experience, you will know when it will lift up and gently you
Yes, sir.
put it in different calyx. You are very lucky in that day. We will be
Yes,
very
sir.
happy
Very happy.
because you
Correct,
only
sir.
can do it. No assistance is required.
Yes, sir. You
You
can
only go and take it. For
take it. Correct,
basket,
sir.
all the cases he has shown,
Yes,
assistance role is very important as he said.
correct, sir.
Extraordinary lower calycial stones you have shown. In
Thank you, sir.
fact, all different varieties you have shown. Yeah, please
Thank you, sir.
proceed, Datsun.
Thank you so much, sir. Thank you, sir. Now, the next set of important area where we want to do is large calculate. I know there are very few people who attempt for large stones, but there are some areas where we can definitely attempt large stone and succeed, because there are area now people are always wanting to come without any incision on the body. So this is an area where we can try to finish such cases in RARS. So a few points to do large stones like this are definitely what I do is always we need a serial dilatation of the ureter is needed. I do a 10, 8, 10, 12 French. If needed, a 14 French, which I rarely use, but 12 French dilatation is needed. And I always put the smallest access sheath if possible. 911 is which we place, and dilate urate to at least one French larger than the access sheet that you place. This is because when you're doing a large stone for 2 hours, 3 hours, you need good access sheath drainage as well as peri-access sheath drainage. So that is very much important to prevent sepsis, stricture, and everything. So this is one of the main thing what we have to think of while doing large stones. And this one or two few side videos are going on. Access sheath should not be tight in the ureter. Again, when we nudge the access sheath through the ureter at the iliac crossing and somewhere above, if it is tight, dilate again and then put it. Always we have I always use a 35 centimeter access sheath, and the thing is placement of access sheath in the upper ureter to prevent damage to more the large, because most of the large stones will be nudging at the PUJ. As you dilate and just push in the access sheath, PUJ can be narrow, PUJ can be obstructed, PUJ can have problem. You can go submucously. So always place the access sheath at the upper ureter and try to go in and start from the PUJ. As you can see, all these stones are from the PUJ, from that area, right, little about the PUJ and pelvis. Always drainage of the bladder is very important for doing large stones. When you go inside, definitely dusting we feel like doing to get fine dust, but in large stones time is important. Always blast into smaller fragments, and laser setting should be adjusted accordingly. So smaller fragments should be the initial objective, then only you can dust, or the fragments which has been there you can always dust it later. Break the easily accessible part of the stone first. This is very important because you have to create space inside the system. It is a completely packed system. You have to create space inside the system and then go on breaking from the sides or from the center, which is easily done. Basketing always can be done to relocate bigger fragments to different places so that you can break it continuously. Otherwise, always if you try to take out the fragments, you will never finish that. So only relocation, basketing can be used and break it. If the vision is poor, again, the assistant is an help here to make it, because once you're doing a large stone, it will be completely cloudy, it will be completely filled with dust and mist. So to clear that, in between you have to see in between that whether you're going in the right track, whether you can see well. So assistant can give you pressure irrigation once in a while just to be sure. So all this pressure irrigation has to come out of the system. That is why the system access sheath placement and dilatation is very important. Stone blasting I've extended up to 3 hours without complication. It can be done properly. So large stones definitely can be done. Definitely, one more thing is the Hounsfield unit. This case was 5 centimeter, but the Hounsfield unit was around 400 to 500. So in one sitting itself, we can actually clear this stone. It breaks very well. So once it breaks well, again you start from the PUJ, go and break the excessive part. You need patience to clear these stones. But if the Hounsfield unit has less, definitely you can clear. And as you can see, this is half of the part of the stone which is cleared. You can see the lower calyx part sitting there. You can go in safely, take your time, 2 to 2.5 hours, do it. But each time, check the position of the stone, check the position at the C-arm, drainage system. Lasix also is very important, that can be given so the system gets trained, so nothing happens. And
And
that is very,
one
sir,
question, Datson.
sir.
When you have a small stone and big stone, this is from Heman Skronjan.
Okay, sir.
If for big stone you start with fragmenting opposite for small stone. That means what he's asking, large stone you attack first or small stones? If you see It doesn't make any difference in such a
That's
large stone.
yes, sir. In these stones, which is almost completing or filling around three-fourths of the kidney, that even if we do the small stone first, the major bulk is still remaining there, sir. If you want
Yeah.
to, or it is nudged somewhere, or the big stone is nudged with the small stone, and you're not able to create a space, definitely break the small stone. You get a space to go inside, then start breaking the big stone. That is the only
Yes.
thing which we can do,
Okay.
sir.
Good.
And
Okay.
thank you, sir. And in this patient, definitely always I do the large stones in two sittings, and this is just to slow we can do in two sittings. And this very important factor is at least a half or three-fourths of the stone, how much ever is possible, you do in the first sitting. You will have big fragments in the kidney. After you fragment it, make it pop dust it or popcorn it so that it becomes very fine dust in the first sitting. Because if you leave big fragments there, next time you go in for the second look, everything will be in the ureter, and you're going to spend another 1 hour doing the strain stress out of the ureter. So uh, break half the stone or three-fourths of the stone in one sitting, nicely dust it, then come out. The second sitting, you can go inside. As shown in this, we can finish off the rest of the stone well. All these stones are not pre-stented, all are primary cases. So for stagon also, pre-stenting is not needed. We can go in, but accessory placement definitely is needed. And so the smaller accessory usually
But if the
9
ureter
11
is
goes in.
tight, you have to put the stent. No, there is no other way.
Definitely,
If
sir.
at all ureter
Because
is tight.
yes, sir. If we don't do a 8 French dilatation and less than that, if we go for a large stone, definitely you can go for a problem. So we need a good ureteric dilatation and drainage of the stone. So that when we do
Okay.
with a smaller accessory, usually it goes through, sir. It goes through. So
Okay.
we can do it, sir. And sir, this is one stone definitely I had to show. This was done recently. The thulium people, all the other stones has been done with the holmium laser. The thulium people bought me a demo, demo 60-watt demo
Yes, yes.
for 1 day, sir. And this stone was posted for Pcnl, because in holmium I'm sure I would take ages to finish the stone, at least two sittings, and the patient wanted clearance, so he came on that day. And this is the CM images which is done on the same day. So it took 1 hour 10 minutes. But and the thing is, the settings and the energies, they were going on changing, showing me different energies and settings. So, but these are the from the PUJ. It was fragmented, and in around 1 hour 10 minutes, the major bulk and everything was completed. So I had definitely planned for a second look for this patient, and this the fifth CM picture at the end of 1 hour 10 or 15 minutes. So all the calyces we went through, and it was he increased frequency, he decreased frequency, increased energy, all the things we did. So that is so the first image showed that is a completion, sir, at 1 hour 10 minutes. So what I came to feel was that day was it is possible. The second is after 1 month, I did check RARs because I was sure there would be a lot of fragments inside. But to my surprise, that is the kidney after the second look, where I found only around one 8 mm and one around 7 mm stones. Rest all the calyces was cleared. It had all gone out. So I think, sir, definitely the
Yeah, that's an
fragmentation
I
and the
will
dust
add.
mite.
I will add a bit of it because last three
Yes,
years I am using this laser mission.
yes, sir.
The
Yes, sir.
main for the audience, I know you have shown excellent videos, but because
Yes,
TFL I am
yes, sir.
using for a long time, probably
Yes,
one of the first to use TFL in
yes, sir.
India.
Yes, sir. Yes,
See
sir.
the
Yes,
frequency, high frequency,
yes,
100, 200, 300
yes, sir.
combined with point 1 or point 2 joules makes the
Okay.
popcorn. You might have
Yeah.
done that very
Yes,
very
sir.
fine dust in short time.
Correct, sir.
So
Correct, sir.
I'm also convinced that after relook, many of the
Yes.
patients this fine dust never gives problem.
Never gives
Only thing
problem.
is
Yes.
that you should have patience to
Correct,
do
sir.
popcorn for minimum time so that your eyes and your brain are convinced that you have
Yes, sir.
not missed any piece. So
Correct,
if
sir. Correct,
you
sir.
put all the fragments in one calyx or one big place
Yes, sir.
and inspect at the end all the other calyces, you will
Yes, sir.
have very good results with this laser. You have
Yes,
done
sir.
excellently well in the first case itself.
Yes, only one.
The question asked by Dr. Samir to you
Yes,
and
sir.
to me
Yes,
also,
yes, sir.
what is your follow-up plan for URS time exceed more than recommended? For example, all
Yes,
of
sir.
us, once we reach certain experience, we try
Yes.
to limit RIRS for 1 to 1.5 hour.
Okay.
So
Okay, sir.
if at all you go more than 2 hours,
Yes, sir.
do you follow up them closely for 6 months to 1 year for any hydronephrosis for the lower ureteric region? Have you experienced any stricture in the ureter in your
Uh,
experience?
yeah, yes, sir. So that's what, sir, for all these large stones which I have shown, sir, definitely it has crossed 2 hours, sir, because above 3 centimeter stones will, if
Yes.
it's little hard stone, it will definitely cross, and we are regularly doing it, sir. And the thing is, the initial steps which we take for the ureter dilatation and the adequate space inside the ureter, the antibiotics and the Lasix and the irrigation also. We don't give initial, only the pressure irrigation is done in between by the assistant. We don't flush it, because when a system is fully packed with stone and you give very high pressure irrigation, you are going to get sepsis. So you don't. So when you follow all these steps, nothing much happens to the patient. We have gone up to 3 hours. 3 hours is the cutoff. I have not gone above 3 hours. 2 hours 15 minutes to 3 hours is the maximum we have gone, sir. And the patient, maybe when we have reached 3 hours, we keep the patient for, usually the patient is discharged the next day, but certain patients we watch one more day and discharge the patients, and we do a relook for all these patients around 6 weeks after that. And definitely they come back at 6 months and 1 year. 6 months we do an ultrasound, 1 year we do a CT. There has not been an instance of ureteric stricture or hydronephrosis till now, sir.
So for the audience, what Datson, with his experience of more than 10 years, like 2012, he started. He is doing up to 3 hours. A small suggestion from my side, probably I also have done more than 15 years. In the initial period,
Yes, sir.
this is a different clinical scenarios is the topic today. It is
Correct.
not a routine RIRS. So
Correct, sir.
he
Correct.
has done so many cases and he is showing iceberg of all the difficult cases. So whenever you do large stone, do not hesitate to stage it.
Stage.
Do
Correct.
not hesitate to dilate it. Do not hesitate to put a stent also. Do not hesitate to do relook. And even
Correct.
3 stages, if you don't produce inflammation, it may be
Yes.
better. As you experience, you know that you are doing
Yes.
quickly and no steps are wasted inside the RIRS, inside
Correct.
the kidney. Then
Yes.
you the water outflow is good and your vision is good. Then just carry without any pressure, as he said, and get away. But for all practical purposes, in the
Yes, sir.
beginning, don't try very hard. Do you agree
Yes.
with me,
Yes,
Datson?
definitely, sir. Definitely, sir. Starting, because initial first 3 4 years also I never used to do large stones, sir. After that
Yeah,
only,
yeah. That is very
and
important point.
yes, sir. I never used to
Okay.
do it, sir, because I was worried about the patient, the sepsis and all. Then slowly, as you
Yes, yes.
rightly said, sir, as you rightly said, sir, initially when we are starting, 1 hour, 1.5 hours, that you should not
Yes,
go
one
beyond.
hour,
And
one and
this,
a half hour is fair enough.
fair enough, sir. 1 hour, and the stone size 2.5 to, that is the correct size, sir. If you go above three
Yeah.
centimeter,
It
definitely
is
staging
difficult.
is better. Yes, certificate
Better.
and staging also, sir. Staging, and that is definitely better for the patient. Definitely, sir.
Yes, proceed, Datson. Thank you. Good.
Thank you, sir.
Very
Thank you,
nice
sir.
cases.
Thank you, sir. Thank you, sir. Now, this is just two short videos just to say the post PCNL scenarios are there nowadays. Also, patients who undergo PCNL also, they want, even when few small stones come in, they want it cleared. But the thing is, they don't want incision on the body. In post PCNL cases, when we do RARS, we find lot of fibrosis and blocked calyces. So before we go in, most of the PCNL will be standard so earlier, so there should not be a problem. So when we go in, what we have to do, you can see the CM images. You should do an RGP first to find out the location and the anatomy of the stone, and the flexible your scope. You have to assess always in the CM, because at multiple calicial bends you might be have, you will not know at what point you did think it is straight, but it will be at a different angle there in post PCL case. So very important that we go in, look at the cases, find the fibrosis, and if necessary, we can cut open the fibrosis with the laser and definitely clear the stones. And post PCNL, one more thing, what happens is the post PCNL, the drainage at certain calyces would be not be proper. So when you open up these calyces, make sure the stone and the fragments are completely taken out, either with a basket or dusted well, so that it doesn't remain in that callus. Otherwise, it is going to stay there like an ESWL. So that's what you should do. This is again another post PCNL. It's a lower calyx. We can see the lower calyx ankle of the flexi there. So when you go in, you feel that the middle calyx is fibrous, lower calyx is fibrous, the ankle is there. But with all these cases, you can use the secondary deflection by nudging it against the callus or nudging it against the pelvis. You can get a little more deflection to reach these calluses. It's because of the dense multiple fibrosis that can happen according to the previous PCNL, that how it was done. Here, it's a small opening at the lower callus. You can see how much the laser fiber is extended, because that's all the flexi will go through. After this, it will not go through. So we can always extend the fiber, reach the callus. The fiber is quite deep inside. Open up the calluses and break the stones. Again, at this point, we can try basketing, but the basket also is quite far away to actually hold on to the stone. Again, your assistant comes into place. See, he is flushing it. He's flushing it. He's continuously flushing it. That stone is completely all the fragments out of it. Once it's out of that difficult callus, you can definitely take out with a basket or taken out. So post PCNL, definitely RIRS can be attempted. But if you find difficulty in the areas where you're doing it, definitely you have to find another alternative for going through. So that's what I just wanted to, I think. Then now coming to the calyceal diverticular calluses, two cases I wanted to show. That is also a calyceal diverticulum is always an area of interest for all of us. You can see uh, the CM images. The first image, we put a dye. We are not seeing. We see the stone in the CT and ultrasound. Second image, you can see something swelling up there in the upper calyx. That is the calyceal diverticulum. So once the diverticulum is there, always again, once we reach the system, you can see the video. I'm inspecting it. You can see a small, looks like an opening there in the upper calyx. So always RGP is a must. You can always place, again, a methylene blue also can be done to find out the opening, to make sure that, I mean, always correlate with the CM. And once it is done, calyceal diverticulum, this is in the upper calyx. So we cut open the calyceal diverticulum, find the stones inside, nicely fragment it and dust it, and then we can take out. The thing is, calyceal diverticulum, once it is opened, again, we have to make sure all the fragments are out of that system. Otherwise, again, it can get stuck there. If possible, you can place a stent into that, so that it remains like that. And these are the areas. So the finding out the calyceal opening into a system is very important. So it will take time. It will you need patience to look into it. But there are areas, and if you cannot find anything at all, definitely you have to go for PCNL or other options to remove the stones. So whatever is possible through inside the calyceal diverticulum, definitely it can be done. That is the last CM image. The last images after the stone is done, we just put a dye into the diverticulum just to show the diverticulum there. Uh, One more calyceal diverticulum. As you can see, again, the CM images, you can see the stones on top and very faint RGP dye is going into the diverticulum, very faint RGP dye. So again, I took almost around 25 to 30 minutes I spent searching the opening in this case, because I went into the upper calyx, going searching everywhere and going, nothing is found. I should have put in methylene blue, which I didn't. But after putting the dye and seeing for some time, I found this that seems to be the opening. You can see one small opening there. Again, I tried poking here and there. Again, feel half an hour to 35 minutes I took. But again, this is the point you can see in the video. That is the point which I had a doubt extensively. But there's nothing else which looks. Otherwise, the calyx look absolutely normal. So first thing what we do is we try to put the guide wire, and it was so tightly closed, that opening, that the guide wire is not passing through. Then still I didn't feel like leaving that. So it could be the opening. I just put in a laser fiber. The laser fiber went through. The laser fiber went through. So I thought, again we opened it. That is the opening there, and we are going into the calyx. The thing is, when you open for a calyceal diverticulum, the mouth has to be widely left open. You can see the stones there. So it has to be widely opened, and all the fragments, you should dust it well. Somehow dusting was done, and then you can see the opening there. So again, the thing is, we made the opening a little more wider, so that it doesn't get closed off. So once it closes up again, it forms stones again. So these are that is the diverticulum there. All the stones were flushed out completely. And here again, that the flushing and taking out the stone fragments is very important. See, the all has come out. Even if you want, while removing the stent, you can always have a look inside whether everything is gone, everything is out. Because always 100% clearance is very important in calyceal diverticulum cases. Now, that is now coming to the last two videos. Again, horseshoe kidney is something, it's an anomalous kidney, which we face once in a while. So, yeah, horseshoe kidneys. Yeah, this is the horseshoe kidney on the right side. Around 2 centimeter stone is there in the pelvis or the middle calyx region. When horseshoe kidney, definitely safely RARS can be done, because many times lab tested PCNL and all that. So before that, we can attempt an RARS safely. Only thing is the ureter might be short, the dilatation of the ureter. RGP is very important. The PUJ, most of the horseshoe kidney will be little narrow. So always very frantic and over dilatation and all that will damage the PUJ. Again, push the access sheath only halfway through, and the rest you inspect with your flexi while going in. Like I am showing in the video, inspect with the flexi the ureter while we go in. Find the PUJ, it is little narrow there. Find the PUJ there, go inside and find the stone. You inspect all the calyces. Calyces are very dependent. So again, once you see the stone, if it is reachable, definitely you can fragment it completely with the stone. We can relocate it to a different calyces. The upper CM picture showing the angle of the flexi is one of the fragment had moved into one of the calyces. So I had to bend at that angle to get the stone out of that. So this is one of the small horseshoe kidneys that stone was done. It is completely cleared. Coming to the last video, this also was recently done. This is another horseshoe kidney. This patient was suggested only PCNL or lab assisted PCNL in 2 sittings. So we thought we'll just assess with the RARS first. Same thing, the ureter was partially dilated. We went inside. You can see the CT picture there. There are 5 stones. 5 stones, one small stone extending little into the, it is not into the isthmus, but part into the isthmus. So the first stone was around 2.9 centimeter in the pelvis. The second stone in the middle calyx was around 2.5 centimeter, 1.8 centimeter in the upper calyx. You can see in the first CM picture where the guide wire is placed, and the small stone there. So what we did was, second was the image with the our RGP done. The third CM image shows the pelvic calculi completely fragmented. Now you can see the middle calyx stones are in a different angle there. The third, fourth CM image. So that is angle at a different angle there. And the fourth CM image is we luckily got that small stone that is nearing into the isthmus there. So this is the video. The first we go inside, this patient was the stone, it was a little infected also. So we gave good antibiotics. The whole stone was done. The thing was, there was the space was less inside the kidney. This stone which I am breaking is the medial aspect, that sorry, the middle calyces is extending to the side. So that is almost a completed view. The upper calyx also was straight, that we could clear. So the pelvis, upper calyx, middle calyx, and now we are just showing the lower calyx. And to the left laterally is where we found the other stone also. So all here. So all those stones was completely cleared. Definitely in this case, we have to do a second look to see the clearance, and it is better to keep the stent for at least 4 weeks and go back and reassess. But in horseshoe kidneys and anomalous kidneys also, definitely the RIRS is an option, and we can always proceed with it. Thank you.
Excellent talk, Datson. I must
Thank you.
appreciate the collection of the cases, recording of the cases,
Thank
CM
you,
images,
sir. Thank you.
enthusiasm to explain clearly. Excellent
Thank,
talk. Very nice talk.
thank you
And
so
there
much,
are
sir.
two
Thank you so
questions.
much.
One from Vineet Sakireddy. Please share
Okay.
your experience with disposable scopes.
Yes, sir.
What disposable scopes you have used, Datson?
Sir, I have used only one, that is OTU. OTU
Yeah.
and OTU is which recently we have started using. Beneath is there, so we have been using it. The thing OTU initially I had a doubt, sir, because we had to use 10-12 access sheet. So, but
Yeah.
because I always use 911 access sheet, I was worried about the ureter, but 911 never gave a problem. But you found that 10-12 also a little dilated. It is absolutely
Yeah.
fine,
Yeah.
sir.
It
And
can go.
OTU scope definitely is a
See,
good scope, sir. It
yeah,
is, and
I
then
will
the
quickly
flexion.
add on to it. I will quickly add on to it because I have used most of the disposable scopes on either demo based regular basis. My
Yes, sir.
commonest disposable scope I am using is Indovasive from Biorad, which is
Biorad,
very
yes, sir.
commonly used in India by many, not only me.
Okay,
It admits by 10 by 12 access sheet as most of the digital scopes. 10 by 12. You need not
correct.
go 12 by 14 as he mentioned.
Yes,
This scope actually has very excellent vision. 21 hours is the time. If you plug in, the time counts. So unnecessary plug-in should be avoided. Whenever you
correct,
start the case, you plug in and then go inside. Don't
correct, sir.
keep it outside after plug-in so that time will not be wasted. 21 hours, some people have done 60-70 cases. On an average, don't be too much optimistic. You can do around 25 to 30 cases
Correct, sir.
if you are good at RIRS. Only
Ye-
advantage is it is around 80 to 90,000. If you break it, you will not lose your heart. If you break the flexible scope Flex X2 or P7, you will break your heart because it is 5 to
Correct,
5.5 lakhs.
correct, sir.
The second scope is, with your permission, Datson, I am just
Sure, sure.
adding.
Please, sir.
Second, because excellent talk, this will be a record forever, so
Thank
that
you,
people
sir.
will get advantage.
Thank you,
Second scope I have used is Pcnl. Pcnl has two scopes. One is absolute 7.5, another is 8.5. This 8.5 was available freely in India till recently. 7.5 Pcnl is the smallest scope available in the world today.
okay, okay.
Biorad also says 7.5, but the shaft is
Yes, sir.
8.5.
It
Whereas
goes only in
Pcnl,
10-12, sir.
Biorad goes only in 10 by 12,
10-12.
whereas
Yes, sir.
Pcnl 7.5 now, which is available in foreign countries mostly, like affluent countries like Europe and US. This is a Chinese made scope where it goes through the 9.5 by 11.5 Cook access sheath, and it has duration of only 4 hours. That is a disadvantage, but the flexibility is extremely good. Vision is very good like Biorad Indovasive. Almost both are same.
Okay, sir.
Cost will be approximately same, 80 to 90,000, all of these scopes. And the third one is the LithoView Boston Scientific, which is very famous in US. The major thing is it is slightly bigger. They have not produced smaller scope. Even 10 by 12, it goes little snugly. Water outflow will not be that good. 11 by 14 access, 11 by 13 access sheet is very good. The Boston Scientific flexion, my opinion, no conflicts of interest in the inferior calyx will be slightly lesser than Pcnl as well as the Biorad, because I have used more than 50 cases, all of them. Even the literature, there are Boston Scientific, they support a lot because all the Western literature is available on Boston Scientific. And now the fourth scope which Datson mentioned is Utoscope, which I have used only for one case. I don't have much experience. I have to call and give. But as far as the many people in North India, they are telling that it is very good scope. It does not have time limit,
No timer,
and
no
it
timer.
is, I think it is Indian made. They are telling in Haryana. The cost is also not very high. Same in
It
the
is
range of these scopes.
correct.
How much is the cost, Datson?
Sir, I think around 70 or something, sir.
Around
70 definitely.
70,000. But
70,000.
they say that around after 20 cases, you imagine that after 15 cases the vision will be less, and maybe
Yes,
20 cases.
yes,
So
sir.
if you do, yeah, Datson.
Sir, that scope, even if they say the lower deflection becomes less, sir. So even if the lower deflection is less, we can
You can
actually,
use for
yes, sir.
upper calicule and middle
Yes, sir.
calicule and
Yes,
pelvic
sir.
stone, so
Yes,
that you
when
can
we,
extend up to 25-30 cases.
correct, sir, correct.
All this the disposable scopes, only one thing they are making is you have to buy their monitor.
Mm,
That monitor is approximately 4 lakhs,
correct, sir.
but that is one time monitor, whereas flexible scope reusable is 5 lakhs.
Correct.
So first time if you buy the monitor, you can connect to your main monitor. But
Yes,
this
sir.
monitor cannot be used for TURP, cannot be used for PCNL, cannot be used for anything. Only for that flexible scope you have to use it. So this monitor issue making people, because it is not that good as Starge and Olympus, Wolf, bigger monitors. It will be slightly inferior. Only for flexible scope they are good. So that is a small finishing summary. Today, of course, it is not the topic. We can discuss later on. I personally feel today Datson George has covered. There is not much to ask. In fact,
Yes, sir.
222, 222 is the audience as of
Oh, thank you,
now.
sir. Thank you,
That is
sir.
great audience. 222 is a big number.
Yes.
I will quickly give my opinion and your opinion quickly. 10 commandments quickly we will go. Number one question: if the ureter is tight, you said dilatation. With what you will dilate?
So the normal serial ureteric
One,
dilator, sir.
one, one line answer, quick.
A serial ureteric dilator.
Ureter dilatation. My
Yes.
opinion is I put a stent and come out. I am slightly afraid of dilatation, but
Yes.
many people are doing dilatation. If at all dilatation is to be done, I do. My favorite is 4 by 6 point for 5 minutes, 6 by 7.5 ureteroscope for 5 minutes, 8 by 9.5 ureteroscope for 5 minutes. Under vision, you keep in the ureter, go and have cup of coffee, so that
Yes.
under vision it will get dilated. This is my
Yes.
opinion.
Yes, sir.
Number two, Datsun,
Yes, sir.
when you use laser for large stone, uh, do you think that outflow of the fluid is very essential for it to be completed, or you don't mind? Because you said up to 3 hours. I have got some questions. 3 hours it is too long.
Yes, sir.
If the case is going well, can you use 3 hours RIRS with a tightly fitting sheath, or better avoid? What is your
No,
opinion?
sir. If the access sheath is tightly fitting, definitely 1.5 hour. Or actually, large stones should not be attempted with a very tightly fitting access sheath.
Okay, answer is
And
done. So for all
yes,
the
sir.
audience, juniors particularly,
For
even
people who
for
are starting,
anybody,
yes,
if you are not comfortable with the elasticity of the ureter, forcible dilatation, long duration of the surgery can lead to stricture, raised temperature. That is always there. But with his experience, he has done a few cases. That is very good. But for the juniors who have done only less than 50 cases, slightly be careful. Don't select a large stone crazily. And if you
yes,
select, do it through 3 4 settings. And if you are very good in PCNL, if the patient is poor, not affordable, PCNL is better. This is my opinion. There will
definitely,
be
sir.
conflicts of interest. It's an open discussion. Now,
Definitely,
fourth
sir.
question: do you use laser in PCNL routinely, or you don't use?
No, sir. PCNL we use lithoclast only, and that is the
Even
PCNL
I use in
only
PCNL
lithoclast.
lithoclast only. Laser is used only when there is chance of migration,
Yes.
when there is a secondary stone which is
Ah, sir.
moving and we are not able to concentrate with the pneumatic. Only these two conditions we use. But the present era has changed. Mini nephroscope, everybody is using laser. It takes time. You will make smaller fragments, but no harm.
So
Fragmentation mode is good. There is no harm. Again,
that
these are all controversial questions.
yeah, Ella,
But
that's
if
very
you
good, excellent, sir. But the problem is when we do, sir, all these small stones is all cleared by RIRS, where the laser needs
Yes.
to be.
Why should we? All these stones are cleared by RIRS. Then why should you do PCNL?
Correct, sir.
PCNL is for large stone removal. Then why to
Correct,
make
sir.
small stones? I
Correct.
strongly agree that.
Correct,
So
sir. Correct, sir.
PCNL, 18 French when you dilate, makes big pieces and take out
Correct.
the 4 5 attempts.
Correct.
You will have
Correct, sir.
SFR better. Is my opinion. Sixth
Excellent, sir.
question: if you stent by chance before RIRS for any non-dilator or infected system, after how many days you will look you will go for RIRS? 2 weeks,
Yes, sir.
3 weeks, 1 week?
So we have gone up to 1 week for
Up to
certain,
1 week.
because certain this Navy patients and all, they have only 2 weeks time. So
Yeah.
up to 1 week we have gone, but ideally 2 weeks is best.
Correct.
2 weeks
So
is
we
preferred.
all look at the 2 weeks, because at the first week end, if you go and again you fail, patient will lose faith on you.
Correct,
So
sir. Correct.
try to be conservative as far as ureter is concerned. This is the
Correct.
sixth question. Seventh question:
Yes.
do you use laser in ureteric stone, large stones? If yes, how do you use it?
Laser in ureter,
Ureteric stones.
yeah, ureteric stone we use lasers. Definitely, we have
Very good.
done only
And
with
do
only with
any precautions you wanted to, you will dust or you will fragment?
yeah,
What is the laser settings?
fragment laser settings. We have 100 watts, so we keep the energy only at zero point 0.3 or zero point 0.4. That is the
Okay, good. That
energy.
means
And
energy is the most important.
important,
Whether you are
important.
using TFL, whether you are using 30
Yes,
watts, whether you are
yes,
using
sir.
60 watts, whether you are using 100 watts, please
Energy.
do not raise the energy more than zero
Yes,
point 0.5. Not required.
correct, sir.
Have
Correct.
patience and make in the center of the stone pieces and
Yes,
then
sir.
take out. So
Yes.
I
If you
think
hit,
you agree with that. There is
yes, sir. If you
no
hit, you should not try to hit the side. If you hit the side, you
side.
mucosal damage, and it will be a problem. So
It will
always,
be a problem.
as sir told, definitely through the center, break it into fragments. Then, if needed, we can dust it, keeping it in the center of the ureter.
Yeah. My seventh question: when do you do PCNL after attempting RIRS? In which cases you feel that RIRS is impossible after
Yes,
seeing the stone in the inferior calyx? When will
yes,
you make your mind, no, this is not my case today for RIRS, convert it into PCNL? When will you do
yes,
that?
yes, sir. There have been certain instances in the lower calyx, which is very nudged. As one is infundibular calculus, sir, which I have shown. This I could get away. Another one
Yeah.
we have to do PCNL, sir. But there are certain stones with we go by the side, we try all the methods, but it is still stuck there in the lower calyx. And one is
Yes.
very, very hard stone. So as I showed, the large stone which I did, that was posted for PCNL. With holmium, to do a large stone in that, I would take lot of, just because the thulium came that day, I attempted, sir. So
Yes.
if it is
Yes.
a very, very large stone, definitely.
Very
But
good. That is
if yes, sir, and if Hounsfield units are less, all the CT we look at the Hounsfield units, sir. Maybe there may
yes.
be at inner stone itself, there may be different areas where the Hounsfield units are different, sir. Maybe only the core is hard. Surrounding may be
Yeah.
less. So I
So
think that
my conclusion regarding the large inferior calycial stone is, if you have a broad base
broad,
which is seen at the periphery of the calyx, if you see only iceberg, you
tip
cannot
of the iceberg.
basket it, you
Correct.
cannot pass the scope by the side of the stone. So if you are even having a powerful laser, if you fragment also, chances of scope damage after the 4 5 cases is increased. Don't be crazy for more than 2 centimeter large lower calycial stone, because PCNL is very easy in such cases. A large base stone, anybody can hit the stone with needle. Even less experienced person can hit the needle and take it out. Whereas in RIRS, you have to bend, especially if the flexible scope is not seeing the stone without laser fiber.
Yes,
Without laser fiber itself it is not bending, then with laser fiber it will not bend.
it will not bend.
So
Correct.
two suggestions: very broad base, and if the all around stone is not seen, and if the flexi is not reaching the stone without laser fiber, then
Yes.
quickly, don't unnecessarily damage your scope, quickly do RGP and think whether you can do it and convert. PCNL is a must procedure.
Yes.
Sometimes it is an helpful procedure when RIRS cannot be done.
Correct.
Last couple of questions, Datson. Have you ever faced tremendous tension after RIRS in the evening with high pulse rate, tachycardia, and hypotension? You should tell honestly. You might have had nightless sleep. Some of the RIRS patients. How do you
Yes.
manage them?
So, the thing is, there's large stones which we started doing, sir.
Yes.
Definitely, I was quite worried, because whether the patient will go into sepsis, will they have hypotension, all that was there for the large stone. And the cases where the basket was stuck and the calycial opening was done, all those cases gave me sleepless nights.
Yes. So
And
if you have done any case with a lot of difficulty, as Datson told, immediate post-operative period, if the pulse
Very
rate is
important.
very high, if the tachycardia is there and the right hypochondrium or left hypochondrium pain is there, you use your antibiogram. If you want to, especially in diabetic renal failure, better to seek the nephrologist advice in the initial stages only with
Yes.
antibiogram. And second thing is, if any hypotension, take it personally, my point of view, that if any hypotension, don't prolong it, use noradrenaline. It all early sepsis, noradrenaline without any doubt has a major role in recovery of the patient, because
Yes.
these hypotensions are primarily because of the cytokine mediated hypotensions. One should be careful.
Yes,
So
we
my
have
last
we
question,
sir, we have changed the
yeah,
antibiotic protocol also. Initially, when this thing we have because we usually give 1 week of oral antibiotics and good antibiotics pre-op on the day, the next day IV 3 times. So
yes,
this
that
this
is
we this
mandatory.
this is
Don't.
yes sir, no
Yes,
compromise on
yes,
IV
yes. Even we
antibiotics.
do 2 3 days of antibiotic if the patient is
Correct,
having
correct, sir.
either fever or large stone is done.
Correct, sir. Correct.
Last question: what is the worst complication you have seen in RIRS in last 10 years?
So
What is the worst complication you have seen in the RIRS?
in my experience, it is this the basket, sir. Two times the basket and the guide wire tip, the hydro tip guide wire, which was. I mean, other than that, there was nothing
Not much.
much, not much, sir. This
So,
basket is one of the
yes.
one which we had seen. So the basket and one more was
Uh,
there when
yes. You are
the lower calyx was
that's
torn and it was cut.
because you are in Lakeshore Hospital, which is a corporate. Probably you got away. I have seen, because I have my own set of hospitals where I am the owner, I am the urologist, so I have to see the post-operative stay as well as the morbidity, mortality. In peripheries, the worst complication is sepsis. Take
No,
it for
no, sir.
granted.
I thought the
Uh,
surgical. So sepsis we have seen, sir. We have had.
uh,
I thought only the
yeah,
surgical
yeah,
you
yeah.
were asking. Surgical, this was the
uh,
complication. Sepsis
I
we
have
had
not seen
initially, sir.
mortality.
No
Lot of
mortality.
morbidity related to sepsis was there initially. So
Yes,
for all
yes,
the audience, first 100 cases,
yes.
outflow of the water is very, very, very important. If the
Yes.
turbid urine is there, don't attempt RIRS. Just
In
overview for the,
sir,
because
initially
these programs
in
are
so initially when we started, I think it was 6 years back. There has been a patient with a patient with a large stone, which we're doing. He had a pleural effusion on the same side. He had a pleural
okay.
effusion because of more water retroperitoneal, and he had a pleural effusion on the same side. This was 6 years back.
Yes, yes.
So
Yes,
post-op
yes. Pleural
initial,
effusion can occur in RIRS,
yes, sir.
especially in upper calyceal zone. If you upper calyceal zone, large time, if you
This was
spend
a
pleural
large
effusion
one.
can
This was
occur.
6 years. So,
Yeah.
but after that, all the methods were changed to a point that it's all done same. But initially, as you said, sir, sepsis we have seen. We have seen definitely,
Sepsis is a very dangerous
and
complication,
it has to
because
be
in PCNL,
encountered
it
immediately, sir.
immediately first few hours when you are done difficult case,
Correct.
keep an eye on
Correct.
pulse rate,
Correct.
TLC and hypochondrial pain. And this is general discussion for the juniors. If the
Correct,
seniors
sir.
are there,
Correct, sir.
they can share their opinion.
Yes, sir.
Datson,
Yes.
lot of appreciation from
Thank you,
many
sir.
people,
Thank you, sir.
many across the
Thank
country
you.
and outside country. People also have followed. This is
Yes.
a very useful program today. I am
Thank you,
very,
sir.
very happy that after a long time we could connect
Thank
and
you so
do
much,
this
sir.
program. Let's
Thank you,
hope
sir.
sometime we will do with laparoscopy also.
Sure,
And
sir. Sure, sir.
say namaste to your father, who is my
Definitely.
mentor, Dr. George P. Abraham, who
Thank you
is
so much,
the
sir.
Don of South Indian urology. And at the
Okay.
same time, very ground to earth. We all consider like our father. You are very fortunate to have such a legendary father.
Thank you
So
so
with
much,
that,
sir. Thank you, sir.
I will conclude the session.
Thank you, sir. Thank you, sir.